Hello everyone, welcome to RAAONLINE. I am Dr. Abinaya. I am a consultant pediatrician. So the topic of discussion now will be on steroid sensitive nephrotic syndrome. So we have been doing the discussion on Nelson based pediatric teaching in the chapter of nephrology. So far we have seen many discussions on glomerulonephritis, proteinuria approach, hematuria approach, etc. So now we will start with nephrotic syndrome. For nephrotic syndrome I have two different presentations. One will be this one, that is steroid sensitive nephrotic syndrome. The other one will be steroid resistant nephrotic syndrome. So let's get started. So first will be the definition always. So as a postgraduate and as a practicing pediatrician, definitely all of us know the definition of nephrotic syndrome. So I'm just recapitulating whatever we know, that's all. Okay. So in nephrotic syndrome we know there is going to be heavy proteinuria. So what is this heavy proteinuria means? More than 1 gram of proteinuria per meter square every day, or if you want to say per hour, it is more than 40 mg per meter square per hour. That is heavy proteinuria. There will be edema and hypoalbuminemia. Something is missing here, right? The dyslipidemia part or the hypercholesterolemia has been removed from the definition of nephrotic syndrome. Now it is only these three: edema, proteinuria and hypoalbuminemia, right? So be clear with the current definition. This is the ISPN. Predominantly this presentation will be of the Nelson textbook and our ISPN guidelines. Okay. So the annual incidence of nephrotic syndrome is somewhere between 1.2 to 16 per 1 lakh children. So nephrotic syndrome, we very well know that the steroid sensitive nephrotic syndrome especially is usually primary, or it is idiopathic. And only 5 to 10% of the patients will have an underlying systemic illness. So the biopsy of a steroid sensitive nephrotic syndrome, in 80% of the cases it will be minimal change disease. Rest of them can have FSGS or MPGN kind of a pathology, but around 80% it is only minimal change disease. Only minimal change will be steroid sensitive. So now coming to the definition of steroid sensitive nephrotic syndrome. Okay, so steroid sensitive means what? First you give 6 weeks of daily therapy, right? So daily therapy of prednisolone for a nephrotic syndrome child, 6 weeks therapy. By the end of the 6 weeks, if the child undergoes a complete remission of proteinuria, that is called steroid sensitive nephrotic syndrome. If by the end of 6 weeks of daily prednisolone at 2 mg per kg per day or at 60 mg per meter square, that is the dose. By the end of 6 weeks, if the child is not going for complete remission, then it is steroid resistant nephrotic syndrome. Okay. So these are the definition differences between steroid sensitive nephrotic syndrome and steroid resistant nephrotic syndrome. Steroid sensitive nephrotic syndrome patients, the outcome is satisfactory because you give steroids, prednisolone, and then for the first 6 weeks, next 6 weeks you give alternate day therapy, the outcome is satisfactory. For steroid resistant, it is not like that. Okay. And among the steroid sensitive nephrotic syndrome, 50% can go for frequent relapses, or they can be dependent on steroids, and around 10% will have late steroid resistance. So I am saying few terms here, isn't it? What is relapse, especially what is a frequent relapse, what is steroid dependence, what is late steroid resistance. So all these might sound a little familiar or a little confusing, but we will make it simplified and we will make it very, very clear for all of you. Okay. Okay. So now coming to the definition of relapse. So relapse means again there is going to be proteinuria. Previously you have a child on remission. Now suddenly there is proteinuria, that is 2 plus or 3 plus proteinuria is there. Again this should be for 3 consecutive early morning urine samples. That is relapse. What is frequent relapses? So you have treated a child, you have stopped treatment after the child has been cured. So in the first 6 months of treatment, discontinuation. So you have completed the therapy in January. So from February to the next 6 months, okay. So July, in those 6 months, if the child has been having 2 relapses, it means a frequent relapser, or 3 relapses in any 6 months. I don't know when the treatment was started or initiated, it was done by some other doctor, so it is like that. So 3 relapses in any 6 months or 4 relapses in the last 1 year. So this will complete the definition of frequent relapses. What is steroid dependence? Steroid dependence means when one is you have stopped the therapy, okay, you completed 6 weeks plus 6 weeks therapy, you have stopped the therapy, within 14 days of its discontinuation, again the child is going for a relapse. Again the child is starting to show proteinuria. That is one. Or if the child is on alternate day prednisolone therapy, that time if the child has 2 relapses, then it is steroid dependence state. Okay, so by now I guess you will know the definitions of these common terms, because we are only going to use the terms from now on. We are not going to explain in detail. Okay, so next few more definitions. Okay, so steroid resistance. Steroid resistance means you have given daily therapy of prednisolone, and at the end of 6 weeks, if the child is not attaining remission, that is complete remission, all the 3 criteria for nephrotic syndrome should go. Edema should go, albumin level should become normal, and proteinuria should become nil or trace. So all these 3 should go, only then we know it is remission, complete remission. Okay, so complete remission by the end of 6 weeks, if it is there, it is sensitive. If it is not there, it is steroid resistance. Again, to make it even more little complicated, we have 2 types of resistance. One is initial resistance, another one is late resistance. Initial resistance means this is the first episode. Consider a child comes to you, have treated 6 plus 6 weeks treatment over, child goes happily without any relapse. Okay, after the 12 weeks completion of therapy, sometime later if the child starts, that means it is a late steroid resistance. In case in the first episode only the child is not responding to steroid, then it is called as an initial steroid resistance. Anyways, about steroid resistance we are going to discuss in our SRNS presentation. Okay, do not worry. So next definition we will go. Stable remission. Stable remission means if the relapse is very infrequent or if the remission is sustained, that is called stable remission. Complicated relapse. This is again, we will talk about complicated relapses whenever we are going to talk about the management. So complicated relapse means relapse which is associated with life-threatening complications like hypovolemia, severe hypovolemia and edema which is requiring intensive care, or when the child has a severe infection, peritonitis, cellulitis, meningitis, pneumonia, etc., or thrombosis. So these 3 conditions, sepsis or infections, thrombosis or hypovolemia, if these 3 are present, it means it is a complicated relapse. Okay. Steroid toxicity. Significant steroid toxicity means what? We know about Cushingoid features, everything, etc. But no, all these are not going to fit here. Okay, here we are going to have only 3 or 4 features. One is your hyperglycemia. Okay. Next one is your obesity. Third one is your short stature. 4 one is raised intraocular pressure. 5 is myopathy, osteonecrosis or psychosis. Okay, so we know these 7 will be the features for significant steroid toxicity. Hyperglycemia means how much? Hyperglycemia means if the FBS is more than 100 or postprandial blood glucose is more than 140 or HbA1c is more than 5.7. Okay, so if these 3 are present, it is hyperglycemia due to steroid toxicity. This is different from diabetes mellitus definition. I hope that much we can identify now, isn't it? Okay, next one is obesity. Obesity, BMI of more than 27. And short stature means height which is persistently less than -2 standard deviation, or height velocity is less than -3. Raised intraocular pressure, cataracts, etc. you will have to send for ophthalmic evaluation and find out. Next will be osteonecrosis and myopathy. Very difficult to find out osteonecrosis unless you do an X-ray. And of course, psychosis is very evident. Myopathy again, some muscle pains can be there. So myoglobinuria and everything. So to evaluate myopathy and osteonecrosis, I think it is difficult. But for pediatricians, for us, at least hyperglycemia, obesity, short stature, because you will keep the child under follow-up, you will do repeated blood glucose monitoring, you will definitely do a growth monitoring and a BMI, like height, weight, you know, then you will calculate the BMI. So that much you should definitely do, and if any of this is happening, and then you can label the child as having significant steroid toxicity, then there is no role to continue steroids, you will have to shift to other immunosuppressives. Difficult to treat steroid sensitive disease. So what are those? Difficult to treat is, one is your frequent relapse. Another one is significant steroid toxicity or failure of more than 2 steroid sparing agents. Okay, so failure of more than 2 steroid sparing agents, that is difficult to treat disease. Okay, and so again this is a comparison of the various guidelines that has come for steroid sensitive nephrotic syndrome. What we are discussing today and what is the latest one is ISPN 2021. I have not dealt much on KDIGO guidelines. Okay, so this presentation will be based on the ISPN 2021 guidelines. If you want, you can go through the ISPN guidelines also, but predominantly most of the points, most of the salient points from the ISPN guidelines are there already in the presentation, so you need not worry at all. Okay, fine. What are the investigations that you will do? Okay, so which are the investigations that are essential at the onset? Fine. So first you will do an urine analysis to look for the proteinuria, complete blood count, you will do a serum albumin. This will tell you if the nephrotic syndrome is present or not. Then the ancillary investigations to support blood urea, creatinine, electrolytes. Total cholesterol, although there is it is not included in the definition, we still do to look for the hyperlipidemia. Tuberculin test, why? Tuberculin test because you are going to start the child on steroid therapy. So you do a MAN2. If it is positive, screen for TB. If it is negative, then if the child is tuberculin positive, you can treat with isoniazid alone along with steroids. Okay, and what are the additional evaluation? Okay, what are the additional evaluation at onset or the relapse? So you do a chest X-ray, renal ultrasound and complete blood counts for infections. Chest X-ray, why? If you get a positive tuberculin test or there is a history of contact, you look for any TB sequelae, or there is a lower respiratory tract infection which the child is presenting now, then again you will do an X-ray. Ultrasound, if you are planning for a renal biopsy or if you are suspecting a renal vein thrombosis, like the child has a gross hematuria which is not seen in nephrotic syndrome, right? So when there is a gross hematuria, of course you are going to do the renal biopsy. What else you are going to do? So of course blood urea, creatinine, all this I have told, and yes, so complement levels, ANA levels, etc. if there are systemic features. ASO level if there is a gross or a microscopic hematuria. Serum transaminases, HbS-Ag, HCV, etc. if there is a history of jaundice or history suggestive of a liver illness. And yes, so this will be periodically monitored depending upon the child's status. Okay, so now we have seen the definition of nephrotic syndrome, then we have seen how all it can present, and now the other definitions. Relapse means what, remission means what, steroid sensitive, steroid resistance, initial, late, frequent relapser, etc. Okay, so now you have diagnosed nephrotic syndrome, you have done the initial workup. Now coming to the management. Okay, so you have done all the tests to confirm the diagnosis of nephrotic syndrome. You have done this additional clinical features, of course, height, weight, blood pressure, everything. So you have done all this, we have discussed. So I am just going to do TB screening. You do the MAN2 test, and chest X-ray also is done. If there is positive tuberculin test but there is no radiological evidence or bacteriological evidence of TB, just give isoniazid alone for 6 months. Okay, so renal biopsy, when all you will do renal biopsy. Okay, so at onset, if there is a gross hematuria with a nephrotic range proteinuria, yes, we will do a renal biopsy because it is not the nephrotic syndrome that we are dealing with. Yes, okay. Next is when there are systemic features, fever, rash, arthralgia, low C3 levels, it can be lupus nephritis. Okay, okay. And after, like once you started, these are at onset. Once you have started 6 weeks of prednisolone therapy, at the end of it, if the patient is not showing complete remission by 6 weeks, of course you will want to see what is the biopsy picture, because minimal change disease will respond excellently to the steroids. So by now, if they are not responding to 6-week treatment, then it can be MPGN or it can be FSGS, right? So beyond 6 weeks, there is no point in giving only alternate day therapy. I have to go for stronger immunosuppressive agents. And yes, for steroid resistance, that's what we are talking about. And calcineurin inhibitors. So in SRNS, our main steroid resistant nephrotic syndrome, our first line agent will be calcineurin inhibitor. So we have talked a lot about CNIs there. Calcineurin inhibitor per se, it is nephrotoxic. So before starting calcineurin inhibitor, you will do a renal biopsy. 6 months you give calcineurin inhibitors. If they do not respond, if the patient don't go for remission, you will do a biopsy. After 2 years, you have completed 2 years of treatment. In the third year, if you are stepping, then also you do a renal biopsy. Simple. Yes, you understood, right? At the onset, when you will do nephrotic range proteinuria is there, but a gross hematuria, it is not matching, right? It is not a proper nephrotic syndrome. I will do a renal biopsy, or if I have a doubt that it can be lupus nephritis, I will do. Otherwise, during the course of treatment, I will decide when I want to do the renal biopsy. Okay. Yes. And age group I forgot to mention. Yes. Age less than 1 year, it can be a congenital nephrotic syndrome. Age more than 12 years, again it is very highly unlikely it is going to be minimal change disease. So, more than 12 years, it can be FSGS, it can be your membranous nephropathy. Okay. So, in such extremes of age we can say. So, 1 to 12 years is like the age category for nephrotic syndrome. Before 1 and after 12 years you will do a renal biopsy. You do a biopsy, what all you will see in biopsy? You will do light microscope, you will see in under electron microscopy, and you will see the immunofluorescence. So, all this you are going to see. And they say electron microscopy not routinely we are doing, but in children where you suspect there is low C3, where there is a gross and persistent microscopic hematuria, and where there is suspicion of glomerular basement membrane abnormality, we do the electron microscopy. Okay. Generally our pathologists do see the electron microscopy, but this is from the textbook. You will have to understand why electron microscopy. Electron microscopy is for to look the immune complex deposition, C3 deposition and all, and for our basement membrane. Excellently we can see the basement membrane like Alport and all, you will be able to see the basket weaving appearance, thin GBM disease and all, we will be able to see only through an electron microscope. So, you need to understand that. Okay. So, we will start with our steroid sensitive disease, how we are going to manage. Before that, you know 90% will have only minimal change disease, so they will respond excellently and they don't need renal biopsy, right? Only before calcineurin inhibitors you need renal biopsy. If I am planning to give cyclophosphamide, if I am planning to give mycophenolate mofetil or Levamisole, Rituximab, even these 3 or 4 drugs not needed. Only CNI. Why? Just I told you, baseline histological changes I want to know, because calcineurin inhibitors, both cyclosporin and tacrolimus are nephrotoxic, right? So, we need to see what is the baseline histological change in the patient. When you do a biopsy, you should know what is the adequate biopsy sample. Of course, it is done by the pathologist or an interventional radiologist, but if an examiner asks you, you should be able to know 20 nephrons should be present, both cortical and medullary part should be present. So, try to include the corticomedullary junction, 20 glomeruli should be seen to exclude the diagnosis of focal segmental glomerulosclerosis. Okay, so for a pediatrician, we should know this much. Okay, so now coming to the therapy. Initial episode of nephrotic syndrome, I am sure every one of us have treated nephrotic syndrome in our, both in our undergraduate also we have seen nephrotic syndrome children, and post graduation you would have treated them left and right, isn't it? So, it is not very new, not at all new for you. So, we will go through quickly, right? Start with prednisolone. So, recent changes you have to write prednisolone or prescribe prednisolone based on the body surface area. Okay, it is not weight based anymore. So, that is a recent change. Remember that. So, it is 60 mg per meter square per day. Every day for 6 weeks you are going to give oral prednisolone either as a single dose or you can give 2 divided doses. If it is a single dose, give in the morning, and no need to give routinely ranitidine or your lansoprazole or omeprazole. Okay, maximum single dose will be 60 mg. That's all. So, this much we have all treated, right? So, I have treated for 6 weeks. Next, what I am going to do? Next, if the child has undergone remission in the 6 weeks, now I will start my alternate day therapy. Alternate day therapy, I am trying to reduce the steroid dose also. Okay. Now, it is 40 mg per meter square. Maximum dose will be 40. Here you can give as a single morning dose. Alternate day only I am going to give for the next 6 weeks, and then I am going to stop. 6 weeks plus 6 weeks, total 12 weeks treatment. Simple. 80% of the patients will respond to this therapy beautifully because they are minimal change disease. They won't come for recurrence mostly. Okay. Dosage based on body surface area is preferred. Other steroid preparations like Deflazacort, all this, please, we are not giving. I have seen old prescriptions of Deflazacort, but they are not valid anymore. Only prednisolone. Single or 2 divided doses can be given. No need of routine proton pump inhibitors or antacids. Not needed. No, 6 weeks you are writing lansoprazole, 6 weeks people write ranitidine. Not necessary. Okay. So now if the patient has not gone for remission, or if the patient is relapsing, now what you will do? Okay. If the patient is relapsing, start again. Okay, the treatment, whatever the dose was there, if on alternate day therapy, if the patient is relapsing, go back to everyday therapy of maximum 60 mg per meter square per day every day. Daily morning the parents will do the urine sample, the proteinuria they will check. If there is remission, that is 3 consecutive early morning urine samples, nil or trace proteinuria, then remission has achieved, they can go back to 40 mg per meter square dose on alternate days. Okay, so this has to continue. Remission usually, whenever there is a relapse, remission usually will come in the 2 weeks. Okay, whenever we are treating, no, so how long this will be necessary? Mostly 10 to 14 days the remission will come. Then we can go back to 40 mg dose. Okay, and yeah, the patient has already completed the therapy. Initially, if the child is relapsing and all, we give the 60 mg dose till the remission is achieved. Then 40 mg dose. How long? Only for 4 weeks. First episode we treated for 6 weeks. If it is a relapse, we are going to treat only for 4 weeks. So this you should know. Okay, and most of the relapses, there will be some minor infections like an URI or any infections that will trigger. What treatment of the infection alone is not sufficient here. You have treated a URI, LRI, and you think that okay, I have treated infection, then this proteinuria also will go by itself. No, it will not remit. You have to start steroid therapy, and remission is achieved maximum by 7 to 10 days. So maximum for 2 weeks you will give the maximum dose therapy, and then you will go for the alternate day therapy for 4 weeks and stop. So late steroid resistance I discussed in the initial few slides. Late steroid resistance means first episode the child responded beautifully. Now the child is starting to show resistance signs of steroids. That is called late steroid resistance. So now in case if we have a child who is relapsing frequently, go back to the definition and read what is frequent relapse. 2, 3 and 4. That is the clue for you. Okay, 2, 3 and 4. Go back and read what is frequent relapse. What is steroid dependence? I am not going to repeat here. Okay, if you remember now, very good. You have listened excellently. Okay, so now we will go to the therapy for frequent relapses and steroid dependence. For frequent relapses, yes, I have given the definition myself. You can go through. For frequent relapses, what if you are continuously going to give steroids, they are at increased risk of corticosteroid toxicity. So my aim will be steroid sparing agents. Steroid dependence, again, they are under high risk of steroid toxicity. So when you give long term steroids, this will happen. So what are you going to do? So for such patients who are frequently relapsing, initially I will try to keep prednisolone at a dose of 0.5 to 0.7 mg per kg alternate day for 6 to 12 months. Okay, if the patient is relapsing at one particular dose, less than one particular dose, I will try to keep that dose. Like at 0.5, if the patient is relapsing, I will try to maintain at 0.7 mg per kg maximum 1 year. Okay, beyond that I am not going to keep the child on steroids. We will have to go for another immunosuppressive agents. Okay, so difficult to treat nephrotic syndrome means if the child has frequent relapses or significant steroid toxicity is there, or they have complicated relapses. These are the children whom we address as difficult to treat nephrotic syndrome. So these children will need calcineurin inhibitors or Rituximab. So difficult to treat nephrotic syndrome. So steroids, so far we have discussed. Who needs steroid sparing therapy? Okay, if they are continuing to show frequent relapses or steroid toxicity has set in, then we give steroid sparing therapy, or depending on the patient's age, severity of the disease, we can start. And yeah, in severe steroid dependence also, after we stop prednisolone, we can start on steroid sparing agent. So to avoid all the confusion, you just remember so far first episode of nephrotic syndrome, I am sure you don't have any confusion, isn't it? Okay, so that is done. 6 weeks therapy is done. Okay. Now this flowchart alone you remember, I will try to explain the other things also here. So you have a child with a frequent relapse or a steroid dependent state. Okay. So now I cannot keep this child on prolonged prednisolone. I have already kept the child on alternate day prednisolone for almost 6 months, 9 months, or say even for 1 year I have kept the child on steroid, but still the child is not going for remission. So now I will address what are the complications in this child. So if the steroid threshold is more than 1 mg per kg on alternate days, or there is more than one complicated relapse, or steroid toxicity has set in, if any of this is present, then this is difficult to treat. It is going in for a difficult to treat disease. Okay, now you don't label it as, but the child might go in for a difficult to treat disease. So before starting your calcineurin inhibitors, you can try with oral cyclophosphamide and mycophenolate mofetil. So even after trying with cyclophosphamide and mycophenolate mofetil, child is still not achieving the remission, then you label this child as difficult to treat disease. Now you can go for cyclosporin and tacrolimus. If on CNI also the child is showing resistance, the only drug we have finally is our IV rituximab, right? Come to the other end. If all this is not there, steroid threshold is less only, there is no complicated relapse, no steroid toxicity, but this child is a frequent relapser and he might go for steroid toxicity. So if we know that, we can try other drugs. Levamisole or mycophenolate mofetil can be tried. Steroid sparing agents can be tried in this child. How are we going to give? So low dose prednisolone means 0.5 to 0.7 mg per kg on alternate days. But giving this prednisolone on even in these doses alternate days can cause Cushingoid's features and all the adverse effects you know. Okay, so you have to keep screening for side effects. You do a height and weight monitoring, you do eye evaluation annually, blood sugar and transaminases at least biannually, you keep doing it. If I don't want to give prednisolone, of course I can start with other steroid sparing agents. One will be my Levamisole, which is given on alternate days for 2 to 3 years. So maximum 3 years it can be given, 2 mg per kg per day. But Levamisole, the adverse effect will be LLL. So leukopenia, vasculitis, so for that L, and high transaminases means liver toxicity. So I just remember like that, Levamisole, vasculitis and liver toxicity. So you have to monitor for counts every 2 months and transaminases every 3 to 6 months. Coming to cyclophosphamide. Cyclophosphamide is also given in 2 to 2.5 mg per kg orally, but it is given every day. Unlike your mycophenolate mofetil which was given on, unlike your Levamisole which was given on alternate days, right? So same dose but every day. Cyclophosphamide, look here, only for 3 months, whereas Levamisole you can give up to 2 years. Okay, and so cyclophosphamide oral is tried and it is given for maximum of 3 months. Cyclophosphamide, we know it can cause malignancies, gonadal toxicities and hemorrhagic cystitis, leukopenia, alopecias, etc. So significant monitoring is needed. You have to monitor the blood counts every 2 weeks, maintain the hydration to prevent hemorrhagic cystitis, and when there are infections, please discontinue it. So all this has to be done. When you give cyclophosphamide, you can co-administer along with prednisolone less than 1 mg per kg alternate day. Coming to mycophenolate mofetil, again mycophenolate mofetil 2 doses, 600 up to 1200 mg per meter square per day is given. If there is no significant steroid toxicity or there is no complicated relapse, initially you can start with mycophenolate mofetil dose of 600 only. Okay, and you can continue this every day for 2 to 3 years. And complications or side effects of mycophenolate mofetil, again these are all steroid sparing agents, like they are all immunosuppressives, so they will cause leukopenias, liver toxicity, again it is there in mycophenolate mofetil also, abdominal pain, diarrhea can be there. So blood counts has to be monitored initially 2 weekly and then you have to continue monitoring it. This is about MMF. Coming to our calcineurin inhibitors, cyclosporin and tacrolimus. Okay, cyclosporin is given at 4 to 5 mg per kg per day in divided doses. Tacrolimus is given at 0.1 to 0.2 mg per kg per day in divided doses. Okay, so you should see the trough levels of these two. When we are giving cyclosporin and tacrolimus, It is ideal to measure the trough levels, that is before the administration of drug, and check if the dosage is appropriate for the child or not. Again, CNIs can be given for maximum up to 2 to 3 years. By 2 years we give, and then you repeat the renal biopsy, and then you take a call to continue beyond the 3rd year or not. Okay. And cyclosporin, tacrolimus, both are nephrotoxic and hyperkalemia they can cause. Cyclosporin will cause gingival hyperplasia, HHH, gingival hyperplasia, hypertrichosis, hypertension. This one, tacrolimus, will cause T for tremors. Apart from that, it can cause glucose intolerance and seizures. So just remember three side effects in both. Okay. So when you give cyclosporin, screen for cosmetic side effects, hypertension, creatinine and potassium, hyperkalemia, hyperuricemia, whatever, how much it is there, etc. You have to do it. Tacrolimus also you have to check for the glucose levels, and hypomagnesemia also is seen in tacrolimus. So magnesium levels has to be checked periodically. So this is about calcineurin inhibitors. So finally, even for calcineurin inhibitors, the child is showing signs of resistance, then the only drug we have is Rituximab. Rituximab is given 375 mg per meter square as an infusion. Weekly, one infusion only. So you give this week, and the next week you can repeat. Beyond 2 doses, if you want to repeat, you have to check for the CD19 levels, and if it is less than 1%, please do not repeat. If it has not achieved that level, you can repeat. Maximum Rituximab is given at 4 doses. Okay. So further discussion of all these doses of all these drugs like cyclosporin, tacrolimus, Rituximab, etc. has been repeated in SRNS also. Okay. So do not worry, there also there is a repetition, and some advanced pointers also have been discussed there. So Levamisole, initially with steroids we start with Levamisole. So it can be given on alternate days, and it can be given on alternate days, has to be continued 2 to 2.5 years. MMF, again 2 doses, 600 and 1200 mg per meter square per day. Every day we can give mycophenolate mofetil. Cyclophosphamide, in steroid sensitive nephrotic syndrome we give oral. Steroid resistant nephrotic syndrome, there is no role for oral, only IV cyclophosphamide. Monthly injection we give up to 6 monthly injections, that's all. Oral cyclophosphamide beyond 3 months we do not use. Okay. And even in SRNS also, when we give cyclophosphamide, we add prednisolone. Okay. So prednisolone is given along with cyclophosphamide, remember that. And all these drugs will have leukopenia as the chief adverse effect. Calcineurin inhibitors we have discussed. Yes, Rituximab also, yes. Rituximab is a CD20 monoclonal antibody. It causes B cell depletion. So when you check the CD19 cells, if it is less than 1%, that is the marker for adequacy of dosing. So if it is still not achieved the dose, maximum 4 doses of Rituximab can be given. And whenever we are giving immunosuppressive agents like calcineurin inhibitors, MMF or Rituximab, we have to start the child on cotrimoxazole. Okay. Okay. So far we have seen first episode of nephrotic syndrome. How are you going to treat? If there is a frequent relapse, or if the child is starting to show sterotoxicity signs, what are the other 4 drugs apart from your steroid? Levamisole, mycophenolate mofetil on one end, on the other end mycophenolate mofetil high dose, cyclophosphamide oral, your calcineurin inhibitors, finally Rituximab. Okay. So supportive care, if there is hypertension, manage with ACE inhibitors or ARBs. Hypovolemia, so maintain the effective circulating volume. So once you can give colloids also if needed. Thromboembolism, of course, prevention of thromboembolism has to be done by encouraging embolism, encouraging ambulation, and maintenance of the fluid properly. Growth retardation, so if the child is consistently showing growth retardation despite all your medical therapy, you have given good nutrition, you have given vitamin D, calcium, phosphate, adequate calcium is given, serum phosphate level is low, all this you have maintained, and still if the child is showing growth retardation and going towards chronic kidney disease, means you can give recombinant growth hormones. So all these are obesity, dyslipidemia, hypothyroidism, everything is a part of, if the child is going to CKD, all this will be there. How are you going to manage? We have discussed in chronic kidney disease presentation. Okay, so you can go through that. What is the stress dose steroid? If a child who has taken the full dose steroid, that is 60 mg per meter square per day steroid for more than 2 weeks in the past 1 year, should receive additional steroids. So if the child is coming to you in a stressful condition like an infection, dehydration or lethargy or any surgery, trauma, stress dose steroids should be given for 5 to 7 days. And so how to identify hypovolemia? So whenever the child is coming to you in a relapse, if the child has hypovolemia, there will be history of abdominal pain, vomiting, lethargy, and on examination you will find this: tachycardia, low volume pulse, low BP, prolonged CFT, cold extremities, postural hypertension, etc. And when you check for the hematocrit, it will be elevated. Your blood urea creatinine ratio will be more than 100. Fractional excretion of sodium will be less than 1. So typically less than 0.5, that is also fine. So all this will tell you there is hypovolemia. If you have a ultrasound machine with you in like an ICU and all, you can yourself do and check for the IVC diameter and the collapsibility index. How are you going to manage edema and hypovolemia? So depending on the severity of edema. Mild means only 7% increase on the weight. Moderate means 8 to 15 and severe means more than 15. Okay. So if there is hypovolemia, we have to give volume resuscitation. So you give IV normal saline 10 to 20 ml per kg, and then you can encourage oral hydration also. If the child is not responding to crystalloids, we can go for colloids. If there is no hypovolemia, only mild edema is there, you advise the child for dietary salt restriction. If there is moderate to severe edema, salt restriction alone is not going to help. So what are you going to do? You will start on diuretics. So oral furosemide you start. If the child is showing hypokalemia, then potassium sparing diuretics, spironolactone is started. If the child is refractory to both furosemide, spironolactone, then you can add a thiazide diuretic, and the another option is you can give IV furosemide also. If the child is refractory to your diuretic, edema is persistent, the option is IV albumin 20%, 1 gram per kg can be given over 4 hours. That is slowly you have to give. If the child is refractory, edema is there, not responding to albumin, not responding to your IV diuretic infusion, the only thing finally for a fluid overload state, we should go for ultrafiltration. What is ultrafiltration? Ultrafiltration means it is a modality of renal replacement therapy which is based on the filtration technique. Here only the water will be removed, solutes will not be removed. Okay, so this technique is only for volume overload. If the child is in AKI or a CKD child, end stage renal disease, I want volume removal also and solute removal also. That time I will not go for ultrafiltration, right? Isolated ultrafiltration means volume overload state, that extra fluid alone I am going to remove. Understood? Okay. So how are you going to manage the infections? So frequent hospitalization, number one cause will be infections only, because we are going to use immunosuppressive agents in the child. There is anasarca, that will be the medium for so many infections. Urinary loss of immunoglobulins and complement factor, all these together will predispose the infections. It is a very favorite question for during the MBBS times, no, during the pediatrics external examiner, very favorite question. So why there is infection in nephrotic syndrome, why there is hypercoagulability in nephrotic syndrome. So I am just recalling all those days. I am not sure if still these questions get asked, but I bet you have already known all this. So I am just moving on. So the most common severe infection will be peritonitis in nephrotic syndrome. The pathogens will be most commonly gram-negative infections like E. coli, H. influenza, and gram-positive pneumococci and streptococci. Among the viral infections, common infections like rhino, adeno, influenza, all these things can occur. And yeah, this is the same thing only, whatever we saw already. So what about immunization? The child is on steroids, should we immunize? What vaccines can be given? Okay, we will see. Killed vaccine, safe, can be given. Live vaccines following certain principles. What are the principles? For live vaccine, what you should do? If the child was on high dose prednisolone for less than 14 days, okay, less than 2 weeks only the child was on high dose steroid, you can immediately vaccinate after the therapy is stopped. If the child was on high dose prednisolone for more than 2 weeks, you wait for 1 month. Okay, you wait for 1 month after the therapy is stopped, and then you give live vaccines. If the child is on low to moderate dose prednisolone like 0.75 to 1 mg per kg per day, you can give Okay, until discontinuation of steroid therapy, you need not give. After that, immediately you can start. Alternate day prednisolone means you can give live vaccine if there is a pressing need. Say there is a varicella outbreak and you want to vaccinate the child. If the child is on alternate day steroid therapy, you need not wait for the therapy to stop. You can give. But if the child was on high dose steroid for less than 2 weeks, wait for the therapy to complete. Like 2 weeks therapy is completed. Now the child is okay, immediately you can give the vaccine. More than 2 weeks, if the child was on high dose prednisolone, wait 1 month and then you give. If the child is on daily dose therapy, low to moderate, till the discontinuation you have to wait. That's all. Okay. What about other immunosuppressive agents? Cyclophosphamide, you wait for 3 months. Calcineurin inhibitors, Levamisole, MMF, you wait for 1 month. That is off therapy, after discontinuation of the therapy. What about Rituximab? Rituximab is a B cell depleter. The child has to wait for 6 to 9 months. Very, very important. Long recovery period. Okay. So what about the household contacts? Can they receive all the vaccines? The contact, the child's siblings, parents, or the whomever is residing. Okay, the contacts can get. They should not get OPV. Contacts should not get OPV. That is very important. Please tell the families, because in the supplementary immunization activities, this is not emphasized. They will take their kids and go and get the OPV and come, right? So advise them. And influenza vaccine has to be given annually for the patients and for the contacts. Very, very important. So coming to the pneumococcal vaccine. So we have to give polysaccharide vaccine beyond 2 years. Conjugate vaccine depending on if the patient has completed the schedule or not. Okay, if the patient is less than 6-year-old and if they are completely immunized, what you are going to do is you give 1 dose of polysaccharide vaccine if the child is more than 2-year-old, 1 more dose of either PCV 10 or 13. If the child has not completed the schedule, what you are going to do is 2 doses of PCV 10 or 13, minimum 8 weeks gap you should give. And if the child is more than 2-year-old, then you can give 1 dose of polysaccharide vaccine. I know it is a little confusing. Please go through this again and again, only then you will understand. If the child is more than 6 years, completely immunized with PCV 10 or PCV 13, you have seen the records, means just 1 dose of polysaccharide vaccine is enough. If they are complete immunization or never given PCV 10 or 13, in this age group, that is beyond 6 years, only 1 dose we can give. 1 dose of PPSV23, that is the polysaccharide vaccine, can be given. Varicella, of course, we have to definitely give 2 doses, minimum 8 weeks gap. Okay. Influenza, more than 6 months annually we have to give for these children. Not only for these children, but for the contacts of nephrotic syndrome also. What about hepatitis B? Hepatitis B invariably everyone is getting because it is available in the government also. So 3 doses, 0, 1, 6 months if they are not vaccinated, or if the anti-HBs is less than 10, you have to give the 3 dose schedule. That is very important. That's all. Hope I have made it very simplified. So we will just, okay, so far if the child, if there is a contraindication to the live vaccine, varicella, you cannot give because the child is on some immunosuppressive agents like cyclophosphamide. Currently, if the child is on therapy of high dose therapy, we cannot give, isn't it? And the child is exposed to a contact. So what you should do? Our first choice will be varicella zoster immunoglobulin. It is not widely available. So next what I will do? I can select oral acyclovir for the patient. If that is not feasible or not available or not willing to give, then we can give IVIG. Okay. So these are the 3 options. If there is no contraindication, the child has completed the high dose steroid therapy and the child is not on any immunosuppressive, then definitely if there is a contact, as soon as possible give the varicella vaccine. Ideally they say 3 days, but it is mentioned as 5 days here. Ideally within the first 72 hours if we can give a varicella vaccine, it is good. So a very, very lengthy presentation and quick revision we will do. Okay. Yeah. So first, definition of nephrotic syndrome. What is the one parameter that was removed from the definition? Yes, you know that, right? So definition of nephrotic syndrome, all the sub definitions. Remission means what is relapse, what is resistance, and what is frequent relapse, what is steroid toxicity, what is significant steroid toxicity. All the terms, definitions, please go through them again and again and again. So next is workup. Then First episode, how are you going to treat? In workup, renal biopsy indications needs a special mention. First episode, how are you going to treat? And remember, for frequent relapse or steroid toxicity, what is the management protocol? Here again you divide. In one end you will have MMF and Levamisole, and other end difficult to treat disease will come. What are the other treatment modalities? And then for all this, what are the complications or adverse effect of the drugs? Supportive care. So a very lengthy presentation, but it is very comprehensive. ISPN guidelines and Nelson textbook both have been compiled here. So I hope this is very helpful for all of you. Thank you so much for the patient listening.